So today with us, we have Dr. Albert Hofman, Sir, the Department of Epidemiology at the Stephen B.K. Family Professor of Public Health and Clinical Epidemiology at Harvard T.H. Chan of Public Health in Boston. So was also the chairman of the Department of Epidemiology of the Erasmus Medical Center and from 1988 to 2016, and has been the science director of the Graduate School of Netherlands Institute of Health Sciences. He's also the recipient of the Folksam Prize in Epidemiological Research and has received an honorary doctorate from the University of Belgrade. We are delightful to have you today with us, sir.
Thank you very much.
So the first question we want to ask you is that because you've been associated with this field for such a long time, what do you think is the biggest difference between epidemiology when you were learning it and how it's practiced by people today, if there has been any difference at all? Do you think there has been a change in the academic backgrounds or diversities of academic backgrounds that students have who now pursue epidemiology?
Yes, thank you very much. First of all, thank you very much for having me, and I appreciate making comments on my favorite topic, epidemiology, I must say. Is it different? Yeah, in some senses, yes, in other senses, no. Of course, the big questions for epidemiology are still there. This is particularly a time when we realize that epidemiology is a very, very important field, and in the sense of the big picture question, in the sense of what should we do in terms of action, I don't think there are real big changes, but there have been changes very much in the methodologic background, in the development of epidemiology, and particularly also in the fact that epidemiology has to follow technologic changes. The technology push for epidemiology has been really very important. For example, in genomics, when we did not have the Human Genome Project and when we did not have genome-wide association studies and the whole type of platforms that we could, there was hardly any genetic epidemiology. Genetic epidemiology is now one of the big fields, and it's a very specific, technologically and also methods-wise, quite specific. Infectious diseases, similarly, that has a very, very developed core of methods that is quite specific actually for infectious disease epidemiology. So if you ask me, have there been changes, it's particularly in that the specialization has gone on. There is a strong input of technology, and we try, of course, as epidemiologists also to keep up with and connect with the basic sciences, because that's really very important.
Right, sir. And so since you also mentioned that today's day and age presents a very unique situation to the entire field of epidemiology, as we know now. So, sir, what do you think, what is your opinion on the steps that the global organizations are taking at this point, global health organizations are taking at this point to curb corona? Do you think it's sufficient? What would be your advice? How do you perceive, what is your opinion and what is happening right now in terms of handling the virus and its infection and the way people are affected by it?
Yeah, that's of course that's a very reasonable question. First of all, let me say I'm not an infectious disease epidemiologist. My field is in cardiovascular and neurological diseases. But of course, if you're the chair of a department with a big group of people working in infectious diseases and in communicable disease dynamics and the modeling, of course, you have to be in there. That's number one. And also what I would like to present to you one of my favorite books. It's from 1942, but it basically is the conquest of epidemic disease. It is largely about infectious diseases. It's Winslow, as I said, 1942, from Yale. It's online. You don't even have to go to Amazon. You just can keep it online. Now, if you read that book, then you realize that this type of what we have here, this pandemic, has always been with us. This is a special one in some senses, but in other senses, perhaps not. We make very often reference to the 1918 H1N1 pandemic. In many senses, this one perhaps looks more like the 1965 influenza one, and not like SARS-1 and MERS, because these were quite contained. What is your question is, what I think of the approaches? Well, I think overall, when you look at the big picture, you realize that number one, this disease is really quite infectious. The reproduction number at the start is somewhere 2 or so, which is much, by the way, lower than for measles and many other infectious diseases. So the distancing that has been presented turns out really a very important measure. That would not work so much with measles, where you have an R0 of 20 or so, but here it works. There's quite some evidence on that. Secondly, that's very important. All the models that epidemiologists have worked on and show that it is of the utmost importance to be there early as you can. A week delay is immediately doubling or tripling the number of cases. So if you want to contain, then you have to be very, very early. Containment, as far as I can judge it, has not really been successful, in the sense of, perhaps it has been in some islands, in Taiwan, to a certain degree in New Zealand, but I do not think that beyond that the containment has worked. Perhaps in some senses in China as well, but overall you see that, and the overall idea that what effective has been distancing. They call it social distancing, but you realize it's physical distancing, and trying to keep the moment that you see people who are ill, have them in quarantine. And that generally has, the lockdowns have worked. I can say this from the New England area, quite hard hit, but now more or less, I think, under control until now. We cannot say yet what is there in 3 weeks or 4 months, but quite well under control, and where there have been no severe social distancing, lockdowns and so on. It goes on, and it goes up and up and up, and it goes out of control, I think. I think that basically is the big picture from the point of view of epidemiology. Distancing, and as soon as possible, if you can, a lockdown.
Right, sir. So a small follow-up to that, as some people, or at least experts, have been saying that when Spanish flu had hit, which was also a pandemic, it had a first wave and it had a second wave. And the second wave was much more deadlier. And it was not just the vulnerable or the elder people dying at that time. It was all sorts of people dying. There was no categorization. Is that a threat with coronavirus as well? That are we in the first wave and the second wave is yet to hit us?
Well, first of all, indeed, it's different. The H1N1, so-called Spanish flu, hit particularly middle-aged people, 20 to 45, 50. In fact, it had less in the elderly, perhaps because of existing immunity, and less in young people, also perhaps because of that. But it's actually not worked out fully why that was. This one is, of course, it's clear, very, very different. In terms of its case fatality, there's no doubt that it particularly is harmful in the elderly. It starts about at 60, 65 or so, and then the case fatality goes up steeply, indeed steeply. It's an agonizing disease. Some people think of it as it's a mild influenza or so. Forget about that. It's a very, very bad clinically disease if you see it. But it is in that sense, more or less in its severe consequences, by and large, restricted to those in older ages. It's not fully true because there are some people who, of course, have compromised immune systems, have really serious pre-existing conditions like heart disease and diabetes in particular, perhaps also obesity. They are at a higher risk, but by and large it is restricted. That has enormous consequences, of course. If we get a vaccine at some time, what do we do? Or if not, and do we have to quarantine our elderly population for, and then in situations where you cannot have social distancing or physical distancing, in many of our big cities where people are packed, and certainly also your big city where people are packed, what do you do then? And what do you particularly do? How do you deal with the elderly? Unresolved, I think, but very good questions, yes.
So just another thing related to what you just said. So we've been hearing for quite some time now that there have been many vaccine trials going on recently in Oxford and a lot of other institutes as well. Is there any way to determine when we will get this vaccine, if we will get it anytime soon, or is it still a long way to go?
Yes, well, what I can say there is to follow the people who are close to it and who are experts, and I follow quite closely generally what Dr. Anthony Fauci says, also because he is involved, of course, directly with the NIH in the Moderna trial, and he sounds cautiously optimistic that he varies a bit in this, but by the end of the year or the beginning of next year, there would be, if it works, there would be a vaccine. The Oxford one is started a bit earlier, so I would think that would be about the same timeline. I hope that this optimism is right. It would be quite unique so fast. And of course, we cannot cut corners in terms of both efficacy, but certainly not in terms of safety, because one of the concerns worldwide, of course, is the increase in vaccine hesitancy. We have, of course, the anti-vax movement that's already there. But now if we then have the impression we are going to, jump into a vaccine, but safety is not guaranteed, then the hesitancy will take up. And so I don't know, with the two examples that we mentioned, there are quite a number of other initiatives as well. I think it's reasonable to infer on the basis of what we've seen until now that there will be an effective vaccine. Effective, by the way, you have to qualify that as well. It's not absolutely sure that it will address 100% of the people. So the efficacy is possible, but not likely, I think, to be 100% as we have in measles or so, or in poliomyelitis. Okay. But there will be one, given that we have what the first response are there and what we read from the literature. So if that's the case, I think it's safe to say that by this time this year, so in a year from now, we will have a few candidates, new vaccines. I hope, I'm not just hoping that it's true, and it may be earlier. And then, of course, the big challenge will be how to distribute it, where to go, and what will be the decision making in that, nationally, internationally. Does that answer your question a bit?
Yeah, definitely. Well, we can hope that soon enough we have a vaccine and things work out.
So another very important speculation again is that the human and animal interaction has to be more fatal than a lot of other things that we consider injurious or toxic to health. Which means that last few threats or diseases which have like scared people have come from an animal source. So is there any research pertaining to this? Are there any hypotheses that are being made currently on this particular correlation between such deadly diseases like Zika or Ebola coming or spreading through animals and affecting humans in a way more deadlier manner than they actually affect those animals as such?
What is your question? Is whether that's a new phenomenon or a phenomenon that we would be particularly worried about?
Yes, sir, precisely. And is it actually a correlation that is worth researching upon, or is it just something that's happened by coincidence for the last few instances?
No, I don't think it's by coincidence. I think it's as I said, it's not my field. But I think when you read the literature, there's quite some evidence that in the cases that we have pandemics, that it was because of the animal-human exchange. I mean, it was the same thing in the bird flu epidemic quite a number of years now ago. And I think if you study the epidemics over a longer time, the two big elements that make them go, and this is, going back to, say, the plague of Athens and further back, the two elements that make them go is one, crowding of people not just individually, but in crowding in the sense of, having villages, and then living together with people, the exchange with people. That is what makes viruses or other agents work. So it's not at all new. It is just the fact that that we have crowded conditions, that we have so much of the animal human exchange, that makes it very well possible, together with one third factor that is relatively recent. The other ones were not recent, but this is relatively, and that is our travel. International travel makes it, and this is shown by the outbreak now, it makes it enormously spreading immediately, even with an R0, a reproduction number of 2, which is not big, I must say. It goes like this, and it's the travel. And it's also very impressive, the data that we saw from China. The lockdown was very, I think, effective from one, but particularly the cutting down the travel. No air travel anymore. I mean, how do you do that is another matter, but from one to another, that seems to be the effective way to restrain and to contain, in that sense, the virus. So your answer is no. It's to be expected. It is also something that we have seen, and there are new elements as the travel, but not something to be particularly, surprised about. May I say so?
One last thing on the pandemic before we move on. So a lot of experts have been talking about different ways to figure out whether or when people might be immune to the virus. So people are suggesting things like serology testing, etc. How effective do you think these methods actually are?
I think that testing at large has a role, a certain role, certainly in in the containment of when you are at a relatively low level of the virus. There is community spread, and that's what we see nearly everywhere. Then the moment you see a kind of little fire, you have to push it out. And testing, serological or otherwise, plays a certain role in that. My personal idea is that it's perhaps the role is a bit overestimated, but it certainly there is a role. The point, of course, is you cannot go on symptoms only, because it's clear now that there is about a week or so an asymptomatic period, which is most likely a very important incubation period. So you cannot just say, well, come and do testing when you have your first symptoms. And therefore, I think it will be limited in this sense. To say, to be used, you see, I have had it, I am now, you see, I have the antibodies, I'm immune, let me go free. I don't think I'm not saying you suggested that, but that is not the proper way, I think, to use these tests. I doubt whether that's a decent way to go about this.
Right. So now moving on to a bit of research and a bit of work that you have done personally. So we believe there's an entire work that you presented that's related to preventing Alzheimer's disease through new methods and new technologies, right? So could you take us through it, or could you share some insights with us here today?
Yes, I most certainly can. It's one of my favorite topics, and one of the things that is wonderful of epidemiology is that I'm an internist by training, so I have an MD, and then I did internal medicine, and that's quite a broad, of course, medical training, medical education. But epidemiology, whatever you're in there, you can choose your favorite topic. And so I started as I said, in cardiovascular, heart disease particularly, and then got very interested in neurological diseases, and particularly in Alzheimer's disease indeed. This was at a time when this was referred to as the silent epidemic. Nobody was really working on it in the 80s of the last century, which is in itself, it's nice to work in a field that not everybody is already in. And so, yes, what are the breakthroughs? Well, this week we published a paper in neurology. You can see it in the New York Times. There's a piece in the New York Times about it, in which we put together the evidence of 7 cohorts in Western Europe and the UK and the US, and we suggest on that basis, it's about 50,000 people in there, and we suggest on that's nearly a 30-year follow-up. Number one, that there's no difference between men and women in the incidence of disease, the new disease, so incidence, not prevalence, existing, but new disease. The risk for men and women, or women and men, is the same. That's for most people a new thing, because most people think that women have a much higher chance, and that is, I think, because there are so many more women who have the disease, but not because the underlying risk is higher. That's one. Number two, and this is in Western Europe and in the US, there is a decline over the past decades of about 13% of the incidence per decade. And that's substantial. And it's very important to have that as a benchmark, to know this in order to then make the next step. Why is that? The question to answer, why is that? We haven't answered that question, but I can give you my favorite hypothesis, that it has to do with good prevention of heart disease and stroke measures, and that is treatment of high blood pressure, treatment of high cholesterol, stop smoking particularly, try also not to get obesity, so body mass index down, physical activity. Those factors have been really much in the center front in preventive activities in Western Europe and the US. And it seems that that has worked. So what is heart and stroke health is also brain health, it seems. That's perhaps not the case in other countries. We have some smaller studies. That's why we did not include them in our analysis, because the follow-up was not long enough. But we have some evidence from Japan, from China, from Nigeria, from Brazil, shorter studies. And that's a mixed picture. It is certainly not the case that in all of those studies the incidence goes down. In fact, most of them is still are in a level of increase, suggesting that the underlying preventive factors are not really working there yet, or still have to be implemented. So yes, it is a prevention that we focus on, because we, as you know, most likely, we do not have a treatment for Alzheimer's disease and dementia. I may say yet, but we have tried quite a bit along the so-called amyloid and tau, two proteins, amyloid and tau hypotheses, and we have not been very successful in that. And so the only avenue we currently have is indeed try to prevent through these cardiovascular blood, circulation-related risk factors.
Yeah, so as you said that we are in certain parts, definitely in the world, specifically talking about the Alzheimer's, the rate is declining and we are able to prevent it much more than we could. Is there any, can you give us any timeline of what further research do you think will go into this field, and by when can we actually come up with certain measures that we would know that following those will probably definitely prevent the Alzheimer's, and hopefully we can also come up with a cure for the same?
Yeah, I'm afraid no. I cannot give very much of a timeline. I, of course, hope that there will be medications available for those who have first symptoms of Alzheimer's disease, or even in a later stage. And there have been over 30 trials particularly on the amyloid hypothesis that have not shown evidence on the various compounds that we have tried. In terms of prevention, prevention really depends on that more or less what are the general causes of the disease, because you can cut them down then. And I think right now the only reasonable ones, and even those are more, in some instances we have not very much evidence, are these cardiovascular risk factors. There is the idea that education plays a role as well. So those with a higher education have a lower incidence. Well, you have to qualify that. They get it a bit later. So, and that means, of course, then that the incidence itself looks a bit lower. That is perhaps possible with educational activities overall to postpone the disease, so that maybe in that sense also be part of the preventative measures. For the rest, we have to wait till we have more very specific, I think, ideas about how to prevention, and what we are currently working in our particular group working on is particularly on blood pressure, and we have very interesting data on how the swings in blood pressure, the variability in blood pressure, when that is big, your chances to have dementia or Alzheimer's are much bigger than when you have a very level blood pressure. Even the level may be higher then, but if you do not have the swings, then your risk of dementia is lower and Alzheimer's is lower. Now, if we know now of treatments that can lower blood pressure, or can not only lower it, but also can make the variability less, then of course we can in that way prevent perhaps Alzheimer's and dementia. That's the type of thing we are working on now. Yeah.
Right. Since we're engineering students, so this is definitely something that we're really curious to know about.
Yeah.
We know that there is a lot of advancement in data science, data technology, the way hypothesis is carried out, the way predictive models are made now, everything is being changed, it's automated. There are absolutely amazing data scientists out there who are working on some groundbreaking technological models. Is it of any use in the medical field, especially in the field that you are working towards, that having hypothesis on diseases and substantiating it with very varying data sets? As you said that in UK, what seems to work is not working anywhere else. Has that part of technology proven to be very useful to your field particularly?
Yeah, it's a very good question. It's the big data, machine learning, deep learning type of question. And I appreciate the question enormously because it's very important. Medicine is a bit different from other fields that we really have to think about causes. We have to think about a causal effect of something. So just prediction, you know, to run a car without a person in it, but just prediction that doesn't work. It works in medicine in diagnostics. And when you you say the imaging and the diagnostics, these big data approaches do in fact better than most doctors. And so that's prediction. But if you really want to know this causes this, then you have to make the next step. And that is, by the way, that's why I appreciate the question very much. That is our effort. We have a methods group, so-called causal inference group in our Department of Epidemiology at Harvard, and that work on various ways to think about causal inference, how to draw causal conclusions from observational data generally, and so how to link that to the big data type of prediction. So instead of prediction, trying to explanation, that's the big word in this case, trying to explain why this person gets this disease and the other one not, that type of pathway, find that out. There will be a role, I'm sure, of big data. In fact, we are ready, of course, we are working with this enormously when we have big cohorts and data sets. And of course, our regression models have worked since the 1960s. In fact, it's a kind of reinvention in this. The logistic model is one of the first. It was the risk function in epidemiology and in medicine was one of the first. But that it will be when it can be connected to this causal thinking, how you can think of a causal effect from A to B. That will be the big breakthrough for medicine. Yeah.
Right.
But it's very important. By the way, one of my favorite phrases is always that it's the technology push in medicine is so important. It's really very important. It is. If you think, as I said, of genomics, what has happened there, that is so amazing in 20 years. But also if you think now of in imaging, all our imaging things that we can do now, which we could not do 20 years ago or 10 years ago even. So if you ask, has the world changed for epidemiology? Yeah, very much in that sense. Very, very much in that sense. And it's one of the
really
key
good
things.
To know.
Very much, it's one of the key things for epidemiologists to stay very close to the technological development. Because if we don't do that, it goes apart.
Right. With that, I would like to conclude this interview. It was extremely enlightening. Both Kartavya and I think, learned so much because this is a very, it's a very rare field that you come across, but it's extremely intriguing to know about it. So thank you so much for sharing your experiences and your opinions with us. And we wish you a good day.
Thank you. I thank you very much for your interest and for having me. And if you wish to contact me or people in our department or so, feel free to send an email and we will be back to you. I very much enjoyed it and I thank you very, very much for your questions.